I get the impression that this talk can be very stiff and formal if I want, but doesn't really have to be. And this seems like a rather small gathering, and I think what I would like to do is talk a little more casually. But I have a PowerPoint, because when you teach in medical school, it's almost a requirement that you have a PowerPoint. And I will go through the PowerPoint, but I will try to be a little more casual in my presentation, because the truth is, I think, and this is something we were discussing at dinner last night, cases are where things come from. Cases are where you get your interests, and cases are where you go and do your work and then learn valuable lessons that will be useful for other cases. And cases are also what are fun to talk about. And if you talk about cases in a presentation, people will remember the cases. Well, if you give a very precise talk, there's a good chance that people won't remember a word that you said. So I will focus a little more on the cases than on precise definitions. I think that will make it a little more interesting. Now, also, though, I'd like to know my audience, because that makes a big difference. So just because I don't know most of you, lawyers, law professors, how many? 2. Philosophers? 2. 3. Sorry. Theologians and pastoral care. Double duty there. Okay. Family physicians? 1. Here I am in the glorious home of family medicine, giving a talk about the importance of family medicine. Holy cow. Hopefully the talk will be downloaded in streaming video thousands of times. And I will reach that audience in the coming months or years or decades. Geriatricians? Okay, well, there's some mystery folks. Social workers? Administrators? Internists? Surgeons? Okay. Anyone else want to tell me? I give up.
Health policy analysis.
Excellent. Okay.
And microbiology.
Microbiology. That, very good topic.
Outreach, which includes pastoral care, clinical pastoral education, and very little other.
Oh, okay. Anyone else want to tell me some deep, dark secrets of their professional life? Okay. Okay. Well, so my topic is assessing capacity. And it's become a real interest of mine, and I was asked recently to write the chapter in the Reichel's book for geriatrics, well-known geriatric textbook on assessing capacity. And I guess I've slowly come to think that, boy, that is the most important topic there is. But it's been a slow revelation. The truth is that these cases and a few others I'm going to tell you about are part of how it dawned on me. And I think there was a point when I started the ethics consultation service in a hospital, and I was seeing a lot of patients doing consults, that I probably would have agreed with the common statement that most ethics is about end of life. And there's something to that. I think the majority of ethics consults include end-of-life issues. But I don't think that's all there is to it, or it would become slowly dissolve into just palliative care. And I don't think it's the same thing as palliative care, and I don't think it's the same thing as pastoral care. And I think it's partially because there are a lot of other issues that we deal with, but we don't recognize. We don't pinpoint that as an ethical issue. And so my view is that actually assessing capacity is an ethical issue. And that has, I think, potentially a little bit of a controversy to it, because it turns out that there are other groups who think that it's their issue. And I don't really mean to fire a shot and start a turf war. The American Psychiatric Association is big and powerful compared to the American Philosophical Association. and I think I was thrown out of the American Philosophical Association, so I'd have to say the American Psychiatric Association is big and powerful compared to the poor little American Society for Bioethics and Humanities. which could fit into this building probably. So I don't want to start a turf war, but I want to identify ways that assessing capacity is something that is an ethical issue that can be dealt with by primary care physicians as well or better than specialists. And in part, this is a question about what is it you're assessing and what do specialists do. And so I think that there are themes here. It could be viewed in different ways. One is, as medicine makes great strides and progress, is it because of more and more technology and great advances in science? And I think the answer is we have more technology and more science, and that's great, but that doesn't solve every problem in medicine. And that's because medicine is a combination of science and human values. It's people. And I think capacity is much closer to the human values and people side of the issue than to the science, including even neuroscience. And so I want to, given the theme of this series, talk about how capacity assessment is really part of humanism in medicine, and so should be done by the humanists. So that's kind of like a kind of general overview, I guess I would say. And the first occurred to me probably 10 or 15 years ago when I thought that ethics consults, oftentimes there's an end-of-life issue there, but it's amazing how many of the ethics consults I was involved in, also they had a psychiatry consult as well. And sometimes, this is what it took a long time for me to realize, I was being called because of what psychiatry had said. And basically psychiatry had said a patient lacked capacity, and either the doctors or the nurses or the family thought the patient had capacity. And so they wanted me to come in and sort of contradict the psych consult. And of course, you're not really supposed to be charting disagreements of opinion with physicians who've consulted on a patient. So it became very touchy. You have to think about what do you say and how do you say it. What do you say in the chart? What do you say to the person? So, gradually I realized that there's certain things you can say in the chart, and then there are other things you just suggest, re-consulting on the patient and give your reasons why you think that the time you saw the patient, they had capacity. So those are kind of the clinical subtleties that I think you have to learn. But I also realized in some of my very toughest and most fun cases, I won because of my superior intellect. No, I won because I realized I had allies. The people who had called me from family medicine and from geriatrics were the ones who were crucial. And so I want to talk about their crucial role and how sometimes you need to make the decision yourself, or perhaps have an ethics consult to support you rather than call for a psych consult. And I think that can be justifiable. So that's kind of the big picture of my talk today. So we can focus on certain parts of this, but it's important to distinguish capacity from competence. The terms get used interchangeably a lot, but I think there's a general agreement about how you should try to distinguish them. So I'll try to make that clear and define the basic components of capacity that everybody agrees on, and how you assess capacity, and then talk about when to ask for help and who if you have a dispute about capacity. But first let me talk about the cases, because this is really the fun part. So my first case is Mr. Allen. Mr. Allen was one of the very first patients I ever saw as an ethics consultant. So I was quite green when I saw this case. And we were called by nursing because they thought that he was threatening them. So one thing I always say about ethics consultation is don't turn down a consult until you've seen the patient. One thing I see people do all the time is they want to talk on the phone and then they decide it's not really an ethics issue. This one, somebody could have said, oh, a violent patient, that's not really ethics. But instead I went to see him and discovered that he was basically refusing to talk to people and going like this and waving his hand. But some people interpret that as trying to strike them. And he was 80 years old and not in good medical condition. And I think if you had stood right in front of him and let him land his best punch 2 or 3 times, I don't think you would have a bruise. So The threat component seemed fairly minor. But there were a lot of other things going on, and as soon as you went up there and talked to the nurses at the nursing station, you heard all kinds of things about him and his family. So he was an 80-year-old man. He had been widowed at least 10 years before. He lived alone in a small, unheated shack, and this was in some place very, very cold, where an unheated shack would be, I would have thought, unsurvivable, to be honest. Not Tallahassee. Some place about 1,000 miles due north of Tallahassee. And he lived in a very, very, very small town. And in fact, his small shack, I don't remember if I put this down, but it was in the middle of a junkyard. And the only heat was a wood stove. And he lived there with 19 pet cats. I don't remember if I put the number, but okay, he had 19 pet cats and also some raccoons. And he fed them all every day. And he loved his cats and he loved his raccoons, and he was very happy being left alone in his shack. The family told the nurses who told me that he was an alcoholic, and he'd been an alcoholic for at least 20 years, and a total loner. He didn't really like anyone visiting him, including usually his family. He came in because he had a pneumonia, which was very successfully treated and very quickly. One of those great miracles of medicine, except that he was that 1 in 10,000 that you read about but you think won't happen, or 1 in 100,000 of a terrible side effect. But it's, you know, it happens 1 in a certain number of cases, and he was the one that got this life-threatening coagulopathy as a result of the antibiotics. So after being in the hospital for 3 days, he no longer had pneumonia, but he had a life-threatening coagulopathy. And he was saying that he wanted to go home. But he had, besides his alcoholism, he had very slurred speech. When you talked to him, he was missing a lot of front teeth, which I think is the main reason he had slurred speech. And if you tried to listen to him, it was very hard to understand, so you had to get very close to him to hear, in which case you got sprayed. So most people really didn't want to talk to him. And there was a question about whether he had capacity, and he said he felt fine and he just wanted to go home. And of course he was being told, well, you now have been cured of your pneumonia, that's the good news, but we have some bad news to tell you, which is that you've had this rare side effect that's life-threatening, and so you're going to have to take certain medicines every day very carefully or you will die. And the feeling was that he was not going to take these medicines and he would die fairly soon. And so social work got involved, and social work was asked to find placement for him. And psychiatry got involved, and psychiatrists came up to assess his capacity, and do you know what he did? He didn't want to talk to them. He refused to talk to them. They would come in the room, say there were psychiatrists, he would go like this. They would then just talk to him and ask him questions, and he refused to answer any questions. And so the staff felt like, well, that must be a sign that he lacked capacity, and they're not going to let him go home and risk his life because of this. And there was all the forces of the hospital were put in motion to find a nursing home and force him to go there. And what was that's really the point that we were involved. Those were the issues. And so it's become for me one thing it brings out is how placement is an ethical issue. And in fact, I think the latest issue of the American Journal of Bioethics, or maybe 1 month ago, was one of the lead target articles was on placement issues with 20 commentaries. And I was very happy to see that, because I think that's maybe because it's not end of life, people overlook it. Like, you know, ethics has to be the big dramatic problems. But actually, ethics is everywhere. And that was a classic example of, I think, placement. Should he be allowed to go home or shouldn't he? And in fact, I mean, I will add, just talking to the family was amazing, because they, nowhere in the record did it say that he had been an alcoholic. So I saw his children and talked to them, and they were the ones who said to me for the first time, well, you know, he's been an alcoholic for 20 years. And I thought, you know, wait till psychiatry finds that out. But they said a lot of other things to me, and when we discussed that case and its outcome, I definitely want to talk about the family's role. He, by the way, in this small town, there was a family medicine practice, and it was a one-doctor practice. At its height, it had been a two-doctor practice, but that's only when the doctor who started it, son graduated from medical school and joined him. But soon after that, the doctor who started it retired, and it was back to a one-doctor practice. But he was a wonderful family physician who ran the practice and who was on the board of trustees of Strong Memorial Hospital. And so one of the questions was, how well does he know this patient, and what does he have to say about what's going on? And we'll talk about how that played into things, too. And then a second case, a little more classic end of life, I guess, was Mr. Bentz, a 75-year-old widower and retired military police officer. Very tough guy, described as a fighter, and I have a feeling that meant both for work and for pleasure. But at this point, he had advanced vascular dementia and end-stage congestive heart failure. He was in the hospital. This was probably already his third or fourth or fifth admission in the past 12 months, and there was a good chance it was going to be his last admission. And the question was whether he should be DNR. And again, this is a case, at first I thought about, this is just a DNR case. Let's use it for teaching DNR issues. His physician in the hospital talked to him about, what is the process of cardiac resuscitation? What is the chance of successful cardiac resuscitation for a man his age and his condition? If he did survive, which is highly unlikely, what condition would he be in afterwards, which is much worse? He would end up certainly on a ventilator in the intensive care unit. Would he want that, or would he rather die peacefully? And he said, oh, no, I would never want that. I've known this day would come, and I've been ready for it for years. Just, if my heart stops, just let me be. And that seemed like no problem, except that when they went back, rounded the next day, and said, good news, we've written your DNR order, so you have nothing to worry about. He said, what's a DNR order? And he didn't have any memory of the discussion. And this was as a result of the vascular dementia. He had very little memory. And so they said, well, DNR order is this, and the reason you might want to consider it is because of your medical condition is this, the chance of successful resuscitation would be that, even if you did survive, you would be here. And he said, oh, no, I would never want any of that. I've been ready to die for years. Just let me be if my heart stops. So somewhere around the third day of this, the question was, well, does he have capacity or doesn't he? And so, again, triggered an ethics consultation. And again, his primary care physician was his geriatrician, who I will talk about also a little bit. So those are two cases of elderly patients. But I also think what's interesting about capacity is when you recognize the importance of capacity issues, it covers the whole range of patients. So for family medicine, you have many patients who are older patients or geriatric, but you also have kids and teenagers. And I think it's fascinating to think about how important capacity assessment is in children as well. And you're probably all familiar with doctrines like the doctrine of assent for children who are young enough that they probably understand what you tell them, but they may not be considered to have enough judgment or appreciation of consequences to give consent. But that increasingly now there's a movement to say that you at least inform them of things and show them respect and let them be part of the decision-making process, even if they're not the ones who are consenting or refusing treatment. So a few examples of pediatric cases: a 14-year-old boy with osteosarcoma who had a 6-month remission, but it's now returned, and he's refusing further surgery or chemotherapy or any life-sustaining medical treatment. So it's an end-of-life case, but for a teenager. And the question is, can you let a 14-year-old boy refuse treatment? His parents were not ready to lose him, and they wanted him to go through more treatment. But his chance of another remission was small, and if it had another remission, it would probably be less than 6 months. So he certainly had a case for his own view. And question is, when do you respect a 14-year-old's refusal of treatment. And again, as I said with the two geriatric cases, you don't have to restrict your focus to end of life. So you can have plenty of cases with 14-year-old patients where there are capacity issues that are important. This was something used in a class that I am involved with, taught to provoke discussions of cultural diversity and respect for people from different cultures. And so they talked about a 14-year-old Native American, and we have quite a few Native American tribes in Florida still. The Seminoles are very big and powerful in Florida, and that's who our team is named after, and it's one of the few schools that so far have still gotten away with preserving their Native American logo with the NCAA by having Seminole leaders come to our campus all the time and say, no, no, we like it, we approve. And then, of course, we give them 10% of the royalties for all the stuff that we sell, so they definitely like us, there's no doubt about it. But imagine a 14-year-old boy on one of the reservations who breaks a collarbone. If they come into the hospital, should you set the collarbone before the tribe elder arrives, or should you wait in order to demonstrate your cultural sensitivity, and recognizing that in that culture it should be the tribal leader who gives consent for medical treatment for members of the tribe. So an outpatient, not end-of-life issue, but you'll be keeping this 14-year-old in a more uncomfortable condition for longer while you wait for this person to arrive. So should you do it or shouldn't you? So basic concept of capacity. I'm going to assume this is pretty familiar, so I want to go very quickly through this. But capacity is usually considered to be something that can be determined by clinicians. It does not require going to court. Competence is usually considered something that requires going to court. Capacity is considered very specific to a task. Are you able to do this? You might be able to do some things but not other things. Example I like to use is you may be able to play checkers but not chess. You may be able to make decisions about advanced directives but not about chemotherapy. So it's a question of your level or your capacity to understand and appreciate the information that's given to you. Competence, being more global and being decided in court, usually has expert witnesses on both sides, and as a result there can be a whole bunch of things lumped together. You might be judged that you need a guardian, and the guardian might be allowed to make medical decisions and financial decisions for you. It has much bigger consequences potentially, but it's a slower and more expensive process of going to court. Also, in the United States, all adults are presumed to have capacity. Autonomy is the medical ethics principle that says that patients have a right to make decisions about their own life. It means self-determination from a Greek word. Its import is the recognition that medical decisions aren't just based on evidence-based medicine and science, but they're also personal decisions based on your own values. So even two people with the same condition being given the same choices might choose different things because they have different value systems, what's important to them. And I think that is a very important step in medical ethics or clinical ethics, is that it has changed the role of physicians from decision makers to educators. This is kind of the lesson I like to make in first year of medical school to the medical students is they might come in there thinking they're smart and soon they're going to be able to make these important decisions for their patients. And so I have to tell them, no, you're smart, and that means you have to be like a good teacher, and you have to be able to sit down and talk with your patients the way a good teacher can sit down and talk with their students. And you have to talk to the patients who are educated so they understand, and you have to talk to the patients who are less educated so they understand. I hope that doesn't mean someone's disagreeing with me. I could be in a lot of trouble. Informed consent, very important legal doctrine which supports patient autonomy and the notion that the patient is the ultimate authority. So the educator role of the physician is to tell the patient all of the reasonable options, and with each of the reasonable options try to explain what are the benefits and burdens for each one, including as one of the options always to refuse treatment. And that's supported by, of course, loads and loads of cases that have gone to court and laws in different states. And there's some variation in how much you have to tell the patient according to different state laws. But I would definitely say the trend, if anything, is toward having to tell the patient more. And there's a whole raft of interesting controversies about, well, do I have to tell the patient that the last patient I had that I did this surgery on died? Or do I have to tell the patient that the hospital across the street has better outcomes than we do? Very interesting questions, not for our talk, but for some talk someday. And right now, I don't think you have to tell that information, but I think the trend might be towards giving more information, and I think that's a good thing. I would defend that.
I have a question about the physician provides information to empower the patient. Is the physician an empowering agent? Is the information an empowering agent? Don't patients become informed through their own internal and social resources rather than having an empowering agent as their physician clinician?
Well, I think the patient will draw on every, yeah,
authority or power to
yeah. Well, I guess, yeah, if I may, if it, I'll look at my wording. If it implies that the clinician is the only source of information, I don't mean that, because certainly patients talk to their family. They now will look on the internet. They might even belong to a support group and have other patients with the same diagnosis, which I think is often a very good thing. So yeah, they will draw information from many sources. But my point is that the physician should understand their role as contributing to that, correcting things that are on the internet that aren't true, or correcting things that they've heard from patients in the support group that aren't true, letting them have a realistic understanding of what the different treatments' advantages and disadvantages are. Help your patient make a good decision, but don't make the decision for them. For example, one thing I've heard, it's been a few years since I've heard this, but I used to hear it a lot from skeptical physicians who felt that they were really superior physicians, experts, specialists. And they would say, in a kind of bragging tone of voice, my patients always do what I tell them. Or maybe they would say, my patients always take my recommendations. Well, you know, at first I thought, I guess I have an uphill battle here, or maybe I'm wrong. And the more I thought about it, the more I thought, you know, if their patient always takes their recommendation, I now become very concerned that they only give them one option. Because I think if there are two viable options and you have 100 patients, it doesn't make sense that all 100 choose option A. You are probably tilting your presentation in a way that A sounds much better than B. And so I think that's why I like the notion that you're an educator rather than decision maker. That's what I'm really trying to emphasize here. And the whole purpose of informed consent, and again, there are physicians who think the informed consent is such a failure because patients do what they tell them. Well, you aren't supposed to be telling them what to do. Other physicians will say informed consent is such a failure because you can do it and still get sued. Well, informed consent was not invented to defend you in lawsuits. It was invented to help patients make informed decisions based on their own value system.
When does the physician take the word of the patient who has a living will and advance directive and doesn't want to have other things, that the physician can't accept those things? Maybe there's something new he wants the person to know about. But in doing that, I just know one case whereby it became such a trial that they had a guardian, and the guardian did everything that the patient didn't want to have done from his advance directive. So I see that if you don't take the patient's...
Right. Well, you know, I don't know. I think advance directives, I will mention them briefly. But for today, I really want to focus on when the patient has capacity. So you should usually not be dealing with the advance directives. Although my view of how to assess capacity does connect to advance directives in an important way.
Like your second case.
Yes. Well, and the other thing is state laws vary. And there was actually a case in Florida, in Orlando, probably 1.5 years ago, at most 2 years ago, in which a patient in the ICU on a ventilator had an advance directive that was considered extremely clear that he would never want to be kept alive in this condition. It was an irreversible situation, and the wife was saying, I don't care what he said in his living will, I want you to do everything to keep him alive. And in Florida, the law is not exactly the same as other, each state's a little different. There it says that the advance directive takes precedent, the living will takes precedent, and if the surrogate, as they're called there, rather than proxy, seems to be contradicting what the patient wanted, they can be removed. And the hospital went to court and had her removed. So, but that won't work in every state. In New York and New Jersey, I think the law is written to tilt in favor of the family, the proxy, as it's called in those states,
well,
who can...
Right, they have surrogacy laws. New York doesn't have a living will.
Yeah, so the surrogate is free to interpret any living will. So it will vary a bit from state to state. But what I want to argue is that consistency of a patient's decisions over their lifetime is an important way to judge whether the patient has capacity. And that, I think, helps explain also advance directives and what to do, because basically what I'm saying is that when they have capacity, you're judging by whether they're consistent over time. So if they lose capacity, what you're trying to do is fill in that same decision. That is, it's still based on what they've done over time. So I think there should be more of a conceptual connection between patients' decisions with capacity and decisions for patients after they lose capacity. So this is what I just said about informed consent. It was never meant to prevent lawsuits. It was meant to add just one more burden to the physician's job, turning them into an educator.
Encourage lawsuits.
Encourage lawsuits, if any. No, but so what the patient must be told, all the reasonable options. Now, I would say the psychological, social, and geographical factors that could influence the decision. Because sometimes I think people want to make the informed consent process as short as possible. Sure, there's a risk of death, but it's very tiny. You don't have to worry about that. There is a chance of some bruising or a chance that you'll feel some nausea, but that's, most patients don't feel that, and if so, it's only for a day or two. That's your informed consent. Whereas I would say the informed consent needs to always include at least an alternative to the recommended treatment, what would happen, benefits and burdens of the recommended treatment and the alternative, and what would happen if you refuse treatment. But also, I like to include how long will it take to recover from this, and what will that period feel like, and where will it be? Because shockingly, I have seen some surgeries done where after surgery, you need to go to a rehab center for 6 weeks, and the patient was not told that until after the surgery. And that, I think, is terribly wrong. Absolutely, you have to include in your informed consent, if you know that patients need 6 weeks of rehab, that should be part of what they decide beforehand. Because tragically, some patients go to rehab, they don't work very hard, it's more difficult than they thought it would be, and they never get out. They go from rehab to a nursing home. And if they had known of that risk, they might not have gone for the surgery. So I think that's very important. Now, a little more about the law. The law says that all adults are presumed to have capacity to make their own medical decisions. And the law doesn't always give us clear answers about things, but this time it does. When are you an adult? On your 18th birthday. And I think it's great that we have a line, and it's the same in all 50 states, which isn't very common in health law. And we all know what it is. The question then is, does that mean that 18-year-olds are presumed to have capacity? Yes, once you turn 18. Does that mean geriatric patients are presumed to have capacity? Yes. 80-year-old patients? Yes. Not 90-year-old patients. Yes. Not patients with dementia. Yes. The presumption is all adults have capacity. Now, you can have an assessment that discovers otherwise, but remember where the presumption is in American law. Now, does this mean that no one under 18 has capacity? Does this mean that all geriatric patients have capacity? And again, the answer is no. It means that the presumption changes at age 18. That's what happens. So you could have a little graph. I think I have one, but I don't think I include it in the PowerPoint. And have, the age of the patient. And at 18, you have a line. And what happens is just the presumption flips. So at 18 and above, everyone's presumed to have capacity, but they can be judged to lack capacity after being assessed by a clinician. Under 18 does not mean they lack capacity. It means the presumption is they lack capacity, but any of them can be assessed to have capacity by a clinician. And I think that's a very important point. So assessing capacity is very important, maybe even more important for under 18. Now, what about patients with dementia? Could they possibly have decision-making capacity? Well, I would say patients with what's called either early stage or mild dementia, it should be assumed generally that they do have capacity. You go and you talk to them, but for the most part, the ability to understand enough information to make a concrete medical decision for right now, yes. If, for example, if a patient has just been diagnosed with dementia, does that mean, darn, it's now too late to work on advanced directives with them? No, that means that it is absolutely the right time to work on advanced directives with them. There couldn't be a better indication for an advanced directive than a patient that has been diagnosed with dementia. Now, maybe you don't want to do it the day of the diagnosis, but you certainly want to say, if someone's been diagnosed with dementia, let's have a follow-up appointment, and that should be top of the list of things to do. Because you know they're going to lose capacity eventually, and you know that they're very scared about what's going to happen to them, and they're going to, at that point, really want to talk about what they do and do not want. So, I mean, to me, to think, oh, they have dementia, it's too late, it's so tragic. I think there are a lot of patients who could make out really good advanced directives, and people say, oh, either they're too upset now, or they lack capacity, or they don't, the opportunity is missed quite often. The way I might phrase the question on that follow-up visit is ask them what conditions they want to avoid at all costs, and then confirm by asking them if these are conditions that they consider worse than death. I think most people do think there are some conditions that are worse than death, and that's what they're most afraid of. And that's a good way to put it, because the presumption of some people is staying alive longer is always better. And you have to be very careful not to impose that view on your patients, because I think what you'll find is that, especially for many older patients who've lived a fairly long life, and they now are facing a potentially unwanted condition, they might prefer death a little sooner to going through that unwanted condition. So you really need to have a very serious heart-to-heart talk with them. I don't think you need to have this talk with every patient on every visit, but certainly patients with a diagnosis of dementia or a terminal illness, probably at every visit, and I would give it at least 5 minutes of time at the end of your meeting. Diminished capacity. Capacity is not all or none. Some patients can make some decisions but not others. That was my analogy of checkers and chess. The most classic one might be that when you ask them about a difficult medical decision, they basically crump or cry or get confused. But if you ask them who they know and love and trust to make the decision that they would have made, they can still say, this is who I really have known the longest and trust the most. And you can't assume that you know who it is. I mean, there are often surprises there. It could be an old friend, it could be someone from church. You have to ask the patient and then have them name a proxy and give them, through legal means, the authority to make decisions for the patient when the patient can no longer make decisions. So I think too often you fear that a patient lacks capacity or they're going to get upset by it, and you avoid all these discussions, including even naming a surrogate, when there's even a patient with fairly advanced dementia, certainly moderate or moderate to severe dementia, might still be able to name a healthcare surrogate, I would say. So now what about if it's advanced dementia? Well, one thing, this is part of an article I just finished come out in a journal called Seminars in Dialysis for nephrologists about should you keep dialyzing patients with advanced dementia. And at the very least, I would say if the patient is screaming and crying during dialysis and trying to escape and needs to be physically restrained or chemically restrained before dialysis, that to me seems like pretty solid evidence that the experience is very unpleasant for them. And if you stopped it, you might be doing the better thing. That might be actually the first do no harm, would be to stop dialysis for those patients. So if they don't have capacity, then you need to talk to their family or to the surrogates they've appointed for consent. But I would go there with a recommendation that it's time to stop dialysis for that group of patients. Disproportionately burdensome, to use the longer, fancier term. So, who can assess capacity? Do you need a psychiatrist to assess capacity? So this might be the heart of my talk. Is the answer to that question is no. You do not need a psychiatrist to assess capacity. I believe everyone who's been trained in healthcare has been told this at some point. But even when it's one of those things that you're told, but somehow you don't believe. And when you're in a tough situation, there's an instinct, especially if you practice in a hospital a lot, to always look for the expert. There is an expert for every organ. Therefore, there must be an expert for capacity, and it seems like, I guess it's psychiatry. Well, I think that there is an expert for every organ, but what you're assessing is not an organ. And there is no expert for capacity in that kind of sense of a technological person who can give a test and give you a perfect objective numerical score with an exact cutoff that's yes or no. So I think it's kind of part of the knee-jerk reaction is a false faith that there's always a specialist for every organ, and there's a technology to measure things more carefully than you can do outpatient. But in fact, this is a classic example of where the person who can communicate best with the patient and who the patient trusts the most is the person who can do the best job. So calling in an outsider makes virtually no sense in most cases. And in the hospital, I saw many patients like Mr. Allen who refused to talk to a psychiatrist. I remember another one, a nice, sweet, older woman with cancer who was judged to lack capacity by psychiatry after she refused to talk to them. But she had, I just remember it was wonderful because what she did was when they came in, she pulled the sheet up over her head. It was like she's hiding from them, and she refused to talk to them. And she did it repeatedly, so she knew what she was doing. She didn't even want them to see her. She didn't want to see them, and she wasn't going to say anything. I went in, and I used my most persuasive line, which was, "Don't worry, I'm not a psychiatrist." And then at least she put her sheet down and looked at me, and I said, "In fact, I have a PhD in philosophy." And I found a lot of patients actually found that so bizarre that they wanted to talk to me. Well, what are you doing here? And we had a very nice conversation in which she explained that she just wanted to go home and die, and that she knew she had advanced terminal cancer, and that if she couldn't take care of herself adequately because she lived alone, there was a hospice in her town, and she wanted to go there because all her friends could visit her. She, was wonderful, articulate. Very, very simple case, really, except for the capacity issue that had triggered ethics coming in. So, now, does this mean that you should never call a psychiatrist? Well, no. I mean, I definitely know of cases where there was delirium, and the standard first-line treatments for delirium did not work, and they wanted to call a psych consult to see if there might be some other new medical treatment that the psych consultation liaison service knew about that the general medical service or family medicine practice didn't know about. So it can be reasonable there. Also, if you have a patient that's had a lifelong psychiatric diagnosis and has been on psychoactive medications and you're having a lot of trouble with that patient, then it makes sense to call the specialist in that patient's diagnosis. So I don't want to say that you never need to call a psychiatrist, but in general, psychiatry's specialty does not include capacity assessment. And this is surprising to some people, but it's surprising to some psychiatrists, but a lot of psychiatrists know this. So it's not like, I don't think I'm starting a terrible turf war. I mean, I've known lots of psychiatrists who say, I hate being called for capacity assessment, and when I'm called for it, I will often say, you don't really need a psychiatrist for capacity assessment. And so, you know, there are well-trained psychiatrists that know that. But there are many psych consult services that I think they're looking for business. They don't want to say no. They don't want to insult the attending. They will come and they will do something. And what they often will do is give either a mini mental status exam, a Folstein, and report a little something about their findings. And then that leads to these problems, because all of a sudden their findings of some memory loss, some confusion, questions about their judgment, a Folstein score of 20 out of 30, and then they don't. Sometimes I say the patient lacks capacity. Sometimes they don't. But the attending gets cold feet. Uh-oh, psych says that their score is low and they lack judgment. I guess they lack capacity. I better do something else. So those cases, I think, the cold feet really started not at reading the note, but at calling psych. And what we need to do is build more trust in yourself for clinicians to do this themselves and to know their patients well.
I totally agree with you about the point about psychiatry. And related to that, and you may be going here, and I don't mean to get too early, but would you relate competency also to rationality, which is often a substitute for
right.
good judgment?
Yeah, I think I am going there next. So let me just here. This is more or less a version of Applebaum and Grissow. There are two psychiatrists who've written what is the most referred to text on how to assess capacity, except that it's I think it's not perfect, and I have some disagreements with it. I would love some time to go to a meeting where I could debate with them about some of their plan. And I don't know if there's a second edition coming out, because it's probably close to 10 years old now, and it's called Assessing Competence to Treatment, which surprises me. But anyways, they suggest that at the very least the patient has to understand the information about his illness and appreciate the benefits and burdens of each of the alternative treatments, and make a voluntary choice and understand the consequences of his choice. This is my wording, but this is pretty close to their first four criteria for capacity. But then they add another one, which they call something like able to reason from values to a conclusion. And it's not quite be rational, but I think it opens the door to the same mistakes as saying that a patient has to be rational. So I would say, no, patients do not have to be rational. In fact, if you ever had a practice where half your patients were rational, I can't even imagine how that's possible. Because the patients are a subset of human beings, and human beings are not rational. So
often it's a substitute, this judgment is not a rational judgment.
Yeah.
Well, that assumes that rationality brings you out of a certain place.
Right.
A lot of decisions that, depending on your point of view, are your place in medical health, may seem terribly irrational to you, but make perfect sense.
That's exactly right. I think many court cases support the idea that patients can make decisions that seem irrational to you, and that's been tested, I think, in all 50 states. So to claim that they have to make a rational decision, I think, has no support at all. And Applebaum and Grissow don't even say that, but they say something like able to reason about their decision. But the closest to that I would be willing to agree might be able to explain their decision. But I even think that is imposing a little too much. So I say if you want to have a fifth criteria, the fifth criteria that I could accept is make a choice that is consistent with how they've lived their life or consistent with past medical decisions. That, I think, is acceptable. And that, I don't think, has any implication or even within the aura of rationality or reasoning. So I think that makes more sense. And there you can say, it also, to me, fits right in with narrative ethics, kind of a booming interest in the notion of a patient's life story as a consistent narrative with phases, but threads that tie it together. I like that notion of a narrative ethics approach, and that consistency of decisions and values over life is one way to test for capacity. So if you want a fifth condition, that would be the one I would say. And then I want to talk about some of the other advantages of that criteria.
Well, I just wanted to say, and when Brock and Buchanan write about that, they say able to deliberate. And I think they say deliberate in order to avoid the notion of reason.
Yeah.
Because of this problem.
Yeah.
And Dr. Simmons was raising. So it's just able to take your own values and what you're told and somehow put that all together.
Yeah, I mean, Brock and Buchanan is a very reliable source. And I think, but you know, like deliberation, back in my early training days, before I went into the medical world, I loved ancient Greek philosophy. And when I had a language requirement, my school allowed me to get away with Latin and Greek instead of French and German. So I love phronesis and I love deliberation. And I have an article about, my first article about capacity was about an alcoholic with weakness of will. And my references were to Aristotle primarily. Still, I think to say that everyone must be able to deliberate might be a little too high a bar. I mean, I guess what I want to say is that when you're in these hospital settings, you're talking about taking away someone's right to make their own decisions about their life. And if they can tell you what they want, and it's consistent with how they've led their whole life, but you cannot engage them in a conversation in which they deliberate about their reasoning, I don't think you should say they lack capacity and try to give the decision-making to someone else. So I want to lower the bar a little lower than Grisso and Applebaum or Brock and Buchanan. We've covered this. So some of the advantages, I think, of the idea of consistency with past medical decisions or consistency with how they've led their life is that it changes who is the expert to the right people. So who are the right people? It's not the psychiatrist. It's not the person who gives a complete neuropsychological battery of exams that goes on for 6 hours. And, and believe me, there are tertiary, and did you know there are quaternary hospitals? So, if tertiary care hospital isn't good enough for you, you can go to the quaternary hospital. And then instead of getting like a quick mini-mental exam, you get the complete neuropsychological battery of exams. That is just going down the wrong path further and further. What you need is to talk to the people who've known the patient for a long time and can say, yep, that's him all right. He told you to go to hell and that he's going home and he doesn't care. That sounds like the man that I've known for 50 years. So you need to talk to the people who've known him the longest. And that, I think, is a wonderful conclusion from the 5th criteria being consistency over time rather than able to deliberate. So you're not going there to see, are they able to deliberate? You don't want to have the expert be the logician, say. I mean, it's great when you have a patient who can deliberate, but I don't want to say that's a requirement. That's sufficient but not necessary. So this is from a friend of mine who's a past president of the American Geriatric Society, Ken Brummel-Smith, and he's the chair of the geriatrics department at Florida State, and we do a lot of our teaching together. So I try to use his slides to clarify some of the differences between effects and benefits. And he's a palliative care board certified physician, and we teach the elective and palliative care and hospice together. But I think in the name of time, I'm going to go a little more quickly. Minors, one thing that is important to me is the mature minor doctrine. The mature minor doctrine is not written into the law in most states, but it has been tested by case law in quite a few states. And it passes the test in some states better than other states. But it's still a widely taught rule, rather like Tarasov. It's one of those things that people learn, but they're not sure exactly when it applies. So to make today's lesson as useful as possible, here is my rule. A mature minor is anyone under 18 who has decision-making capacity. And then that makes you appreciate that, well, there are a lot of people under 18 who can understand what's wrong with them and appreciate the consequences, the benefits and burdens of each choice, and what would happen if they refuse all treatment. And they can make decisions, and it's voluntary, and based on a value system that they have. So I think many, many people under the age of 18 have decision-making capacity and are mature minors. And I think the consequences of this can be as surprising and difficult to accept in pediatrics as for some older patients in geriatrics. But I think that to me is the part of the job. A geriatrician's job is to fight for older patients' rights, and a pediatrician's job is to fight for teenagers' rights. Not that every teenager can make every decision, but think about it before you cut off their right to make decisions. Talk about them, explain things in terms they can understand, help them grow, and help them develop the maturity that a mature minor doctrine implies. So can adolescents ever be considered mature? Well, one way to think about it is at age 18, the law presumes they're all mature. So is there a great miracle that happens when they go to sleep the night before their 18th birthday and none of them have capacity when they're 17 and a half and all of them do at 18? Well, no, that is not on the short list of miracles. It's a developmental process, and it's a developmental process that ends at 18. So, you know, my rule of thumb, because it's a fantastic word. It's my favorite word. It might be my favorite word. It's a great word, and it's an English word, and I like English a lot because I could never learn any other languages. I could translate some Latin and Greek, but I couldn't do French or German because I'm so bad at speaking other languages. So anytime I see an advantage of English over other languages, I want us to promote that, okay? So let me promote the superiority of the English word teenager. And, you know, that suffix, starting at 13 and 14 and 15 and 16, it's great, and not all languages have it. And a lot of languages that don't have it, when you listen to people speaking Japanese or French, you'll hear the word teen in there because they've adopted the English word, because it's just a very good fortune that it starts at about the right time. So my rule of thumb is whenever you are talking to a teenager, think seriously about whether they have capacity and are a mature minor. And by the way, am I a crazy radical philosopher? No, I'm not that crazy, I'm not that radical, and I'm not even sure if I'm a philosopher anymore. I have the backing of the American Academy of Pediatrics, and I could give you a few references. They have like 3 position papers on this, and basically they say around age 14 or so, most teenagers have capacity. So if you cross the 50% line at 14, and you're at the 90% line at 18, you can see that, you know, starting at 13 to start thinking about this is very reasonable. And that's what this says. An assent. Let's see. If a patient is making a decision that you don't like, and so you think it's irrational, is that evidence that they lack capacity? I mean, that kind of thought has been ruled out many times, and I think one thing you always have to consider is whether the recommendation you made or what you think is the only reasonable option really is the only reasonable option. And I think a lot of times we live in the hospital world, and our value system gets a little bit distorted by that. So I think maybe if you're outpatient, that's not as true, but I mean, I spent 10 years where I was only in tertiary care. I didn't see any outpatient cases. And boy, you know, the world does change, and it's a specialist and a subspecialist, and it's very easy to think that decisions are irrational when you see them in the hospital, then in fact they're normal everyday decisions outside of the hospital.
You wonder, if I may, how that number 18 got into the vocabulary and legal standards of the United States. And wonder if there are not social and political standards involved in that, as well as assessments of capacity.
Yes.
There are 2 things. One is there are an enormous number of children who are dying who show remarkable insight into their condition.
Yes.
And often are more mature about it than their parents are.
Absolutely. I agree with you totally. I agree with you. I think parents often love their child so much that they cannot make a rational decision. And children can often be the more rational. And I think that's true in a lot of decisions. I mean, I think that's something that we have to consider. You know, just like if you're white, you have to think, is it possible that I have a little racism? That, you know, I don't like or don't trust black people? You have to worry about it. You have to make sure it's not true. You have to, if there's a little bit of that in some cases, you have to identify it and recognize it and compensate for it. I think, or sexism. If you're a man and you might have an old-fashioned attitude that if you call women ladies sometimes, you might just have a certain assumption that they are naturally take advice from men or something like that and paternalistic. Well, I'd say the same thing for if you're over 18, and especially if you're in your 50s or 60s or 70s, and it's been a long time since you were a teenager, you might really underestimate them. I think that's a real common situation. So yeah, I like the word teenager, and I think that if you talk to them, you'll often be surprised at how much they understand what's going on and how much they're making a decision that's perfectly reasonable. It's just not the one that their parents wanted or not the one that you wanted. Because if you're an oncologist, say, and you still think there's a 10% chance or something. Again, here is just an attempt in a kind of concluding way, because I want to have lots of time for discussion too. But I think teenagers provide useful guidelines for patients with early dementia and developmental delay, and also psychiatric patients that are well controlled with medication. Namely, oftentimes they have capacity, and it's very easy to have a bias that they lack it because of their psychiatric diagnosis or because of their age. And I think that's a mistake. Try your best to help them make decisions that reflect their value system. Don't too quickly assume they lack capacity or call for a psychiatric consult. Remember, just like teenagers, you show respect by encouraging their participation. Don't talk down to them. Don't talk to the other person in the room instead of them. Make eye contact with the teenager or with the person with dementia and talk to them. And they often will respond like, it's so great to have a doctor who cares about me and is talking to me and isn't ignoring me. I'm still in the room, you know, I'm still here. At least try to get their assent, make sure they understand what the plan is and that they can agree to it if it's at all possible, even if you think they can't give consent. Remember how much difference a year can make. I mean, for teenagers, a year can be an incredibly long time, and they can really be much more mature a year later. So don't think because they were 12 or 13 last year and seemed immature that they can't understand things now. And remember that your tone of voice can influence the kind of cooperation you receive. And I think all of these things are true for dementia too. Dementia patients, how much difference a year can make is the other direction though. Don't lose your window of opportunity. And let's see. Well, maybe quickly. For the pediatric cases, you can probably figure out now what I would say. The 14-year-old boy with osteosarcoma after a 6-month remission, I agree with you. It's surprising how often they understand things better than we do. We're the ones in denial. They're the ones who are giving a realistic assessment. Can you just refuse to listen to the parents and say, I'm going to take your kid away from you and let them refuse treatment? No, you never want adversarial situations. But you should recognize that your goal in that kind of case might be to work out the relationship between the parent and the teen in the teen's favor. Don't assume because the parents are your age that you're on their side.
I'm curious whether you were referring to that 14-year-old Florida boy that the judge did find him able to make his own decision. He and his parents got at crossroads, and social workers and policemen showed up to arrest him and take him back to the hospital for chemo.
No, I think, I can't remember the details of that case. There was a case a year ago that was in the news a lot of I think a 15-year-old in Virginia that wanted to go through alternative healing and prayer.
On the Eastern Shore.
Yeah, on the Eastern Shore. And that one, I mean, that was not a happy case in my opinion. I have a feeling it was mishandled. And
well, they said he needed radiation as well as chemotherapy, and
yeah.
He said we don't want to do the chemo.
Yeah.
And the doctors ultimately compromised and said, okay, we'll just do RT without chemo, which is not treatment of choice.
And maybe the last information I had about it, maybe you have more recent, was it became a court battle, which I think, you know, the purpose of keeping things at the bedside whenever possible is avoid court battles, and the purpose of ethics consultation especially is often to avoid court battles. But when it went to court, the courts were choosing between the hospital and the parents came across as incredibly concerned and loving, and the court sided with the parents, and which I think was sad because the boy probably had a better prognosis given the particular condition he had, which was I think lymphoma, and instead he's going for like enemas and prayer in Missouri is the last I heard. So I think avoid court and avoid adversarial and try to find a way to get, you know, the second best treatment is not as good as the first best, but it's better than nothing. So negotiate and stay engaged. Don't become adversarial. And if you take it seriously, there are a lot of things that you might want to think about. What are the rights of teens to talk about the HPV vaccine? Should be the rights of teens to talk about whether they're going to be taking Ritalin or antidepressants? What about anorexia and force-feeding teenage girls? In each case, what happens if you think of it as a capacity issue and talk to the teenager first? And can you enroll them in a decision with you as your ally and partner rather than taking an adversarial or paternalistic approach? And that is my talk. So I want to thank you for inviting me here.
I'll open this for questions, but I have one favor to ask, so that it'll be picked up on the web stream. If you could repeat the question when someone asks you a question before you answer. Questions?
Two things I have learned a long time on the ethics committee here. One of them, I am just a poor lawyer, and it frightens me no end to hear a radiation oncologist argue with a surgical oncologist what is the best treatment. This presenting information objectively is less objective than I would have liked to have thought as a non-physician. The different physicians have different ideas about what is right. And the other thing I learned from the ethics committee, and this has been true from the beginning, and David does a great job of it here, and that is the role of risk management. We can advise an ethical outcome that we like, whether we could ask the hospital to expose itself. You've got somebody with dementia, and somebody is there thinking about, can this hospital risk its accreditation, its money, everything else.
Yeah. You know, yes.
That we think is ethical.
Let's see now, do I need to repeat those two? I kind of thought they could hear that one. Yeah, so I think risk management is a very important player in a hospital scene. And if you are going to be an effective ethicist, you have to know about risk management, and you have to know who does risk management, and they have to know you. And you have to trust them, and they have to trust you. And part of it is they have to know what cases, and I have been involved in hospitals with great risk managers who will say, when they hear something about a case, they say, no, 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 don't tell me anymore. I don't want to hear about it. You would not want to hear the advice I would give you. Call for an ethics consultation. Now, if you are blessed enough to be in that kind of hospital, you're very lucky. If not, then you have to work towards that goal. You have to get to know the people that do risk management and let them know that there are cases that are going to have legal issues, and they are better off having you in the case than not having you in the case. And my argument for why hospitals should pay for ethics consultation, which I do believe every hospital should have ethics consultants who are paid to do that job. And part of my argument for that is that a good ethics consultant will prevent maybe one lawsuit a year, which would pay for a salary of about $1 million. And I will give you my email address if you would like to hire me for that. I will come for $1 million, no problem at all. But no, I think that the truth is that a lot of ethics cases have major legal issues in them, and we are trying to resolve them without it going to court. And so I think that that's an important role for ethics consultants. And the risk management has to understand that and use us properly. And don't let risk management control the hospital and turn every doctor into somebody who practices defensive medicine, because that is definitely bad medicine. And there's two questions that I'm waiting for someone to ask. What happened to Mr. Bentz and what happened to Mr. Allen? Yeah. So let's see. First, Mr. Bentz, he had dementia, moderate to severe dementia. He agreed to a DNR order, and then the next day didn't remember a thing about it. And yeah, about what? And I think for me, he's the perfect example of why the Folstein is totally inappropriate. And anytime a psychiatrist who's called to do a capacity assessment uses the Folstein, you actually have proof that the psychiatrist should not have been called, because the psychiatrist does not know what capacity is. They made a terrible mistake. So just like a patient who says they won't talk to a psychiatrist, is that proof that they lack capacity? If anything, I think that's evidence that they have certain kind of judgments, right? They know what psychiatrists are, and they know what's at stake. So, you know, I don't think that refusing to talk to psychiatrists proves you have capacity, but if it's evidence that you do or don't, it's evidence that you do have capacity. So, Mr. Bentz, there was great concern, and what really turned things around was when his outpatient long-term geriatrician came in to see him and said to the team, I think so long as he's making the same decision every day, each time he understands it for that 5-minute window, and he's making a decision that reflects his capacity at the time. And furthermore, I think that, you know, this is totally consistent with his life. He was a fighter, but he liked a good fight that he could win. He would not want to be left in a debilitated state on a ventilator for a few weeks in the intensive care unit. And indeed, it is true that he has told me that he's been ready to die. When the time comes, you know, it's going to be good for him. He's ready for that. So the DNR order was written and kept in place, and he died about a week later.
Isn't the fact that he can reword this, reinterpret it in his own words, imply that this is a basic fundamental value of his, whether or not he uses the DNR vocabulary? Right. Now, I agree. I think that falls under the, I don't know if it's exactly giving reasons, but explaining, just rewording, paraphrasing. He said, yeah, I'm ready to die. I'm not afraid to die. I think that's right. So these are the kinds of things that you go there to the bedside and you talk to the patient and you discover. And it does not require a battery of tests.
It has to do more to do with the formulation of the goals of care. And if we look at what a patient wants in terms of an end result, which he was able to do consistently over and over again, without actually remembering what he said, he's able to go ahead and articulate what the end result is. I know I will die. I know I don't want you doing this thing. This thing is something I don't want. Don't do this thing. And to go ahead and say, well, now we've got to go ahead and visit it again and again to go ahead and make sure that he really doesn't want it. That's really just, they're just going through an artificial machination of making sure that he can do an informed consent for their own desires. But he's saying, if I'm going to die, this is the appropriate time to die. Allow me to go ahead and die at this time. That was the important part of the conversation. So when I assess capacity for a patient, what I'm looking for is, do you understand what's wrong with you? Do you understand what your options are at this time? And you know where you're going in terms of the goals of care. And if they're able to say, yeah, this is what I want, this is where I'm going, then they have the capacity to make the decision on their own. Do they know how to draw a intersecting pentagon with a square? Do they have the ability to spell world backwards? No, not at all. But who really gives a darn if they know that they really don't want to have a resuscitation and they've got metastatic carcinoma?
That's exactly right. Now, I do often, when I talk to the lay public, though, I will say some of the things I've said in this talk, but I will also say, just to be on the safe side, I recommend that everybody memorize how to spell world backwards. And also memorize counting backwards from 100 by 7s. There's a few things that could come in useful. Let's see. And Mr. Allen, let me tell you about my other patient, Mr. Allen. that one turned into a meeting in the executive boardroom of the hospital that included the head of legal counsel for the hospital, who was in charge of the whole risk management office, and included the head of social work, who saw this as a placement responsibility. I was arguing for let him go home, make the best plan you can to try to get him to take his medication every day, but if he doesn't, he doesn't. But let him go home. Turns out at this meeting a lot of things came out, like that he actually owned the junkyard, and it was fairly, valuable piece of property. And that he had supported himself for years selling flowers in his small town, and everybody knew him. And that he probably is more socially functional than people realized. And then his family medicine physician showed up at the meeting, who, as I said, was on the board of trustees, and was the son of the person who founded it and had been on the board of trustees. And this wonderful doctor said, "This is what Mr. Allen has always been like. When he feels sick, he comes to the doctor's office with no appointment, and I see him, but that's how he is. And he's popular and well-known, and it would be terrible to try to force him into a nursing home when he's protesting so much. And I think if he went to a nursing home, he would probably escape unless you tried to tie him down, and I would never want that." And the children said they would never sign any consent form for their father because they said they thought he had capacity. He's managed this long like this, and they're not going to ruin his life and try to take control over his life. It was his right to make the decision. And the hospital, I think, winced. They weren't happy, but they let him go home. And I got a report back from the family medicine physician that he went home and he sold flowers on the street corner as he always had done, and he bragged to everybody about how he had outsmarted all the doctors at the hospital. He was the happiest he had ever been. He had something to be so proud of. and now, his outcome, he lived for, I think, a few months. And that was because his kids would go and try to count the pills, and a home nurse would come occasionally. And when he came to the doctor feeling any, sickness, the doctor would try to push him to take the pills. So he did it for, it was probably, a month or two at least. But it was long enough for him to have one final triumph in his life. And he died at home with his kids there at his bedside while he was asleep.
Well, I just want to say that in the literature, the ethics literature, there's discussion about whether the capacity is a matter of degree, whether one can have capacity more or less. Mm-hmm. And I take it that your response could be something like, well, whether it is or not a matter of degree, that these criteria you have here, which you take out of Applebaum, those have to be met. So that even if it is a matter of degree, there has to be a this degree in order to be what you would count as.
Right. So the question was, in the ethics literature about capacity, there were some things written about how capacity might have degrees. And it became, some people became very angry at that suggestion. And I'm not sure that I've understood fully why they get angry at it. But I think what I would say is that, first thing is, in reality, capacity can fluctuate wildly in the hospital. If you talk about somebody who's frail and sick and on 5 medications, they might have capacity at 2 o'clock and lack capacity at 4 o'clock. So that's one important thing just to recognize in, in real life practice. Another thing is that if you set the bar low, there's not a lot of testing or reasoning that's necessary to have capacity. A third thing is, a lot of times the problem is how things are explained to the patient. So if you have a kind, caring patient physician who sits down at eye level and makes eye contact and uses plain, everyday, folksy language, and can take 20 minutes or 30 minutes to talk about things, I think you will find that's how you maximize the number of patients that have capacity. And I do think some decisions are more difficult than others, or more complex than others. I don't know if I'm saying capacity has different levels. I think that seems to be what has bothered some people. If you read Applebaum and Grissow, it sounds like they were kind of influenced by that view, actually. And I'm not sure that it really helps their argument particularly.
Any other questions?
Well, this is something to explore anyway. What exactly is the value of an assent as opposed to an informed consent? This is a problem particularly in research, where somebody can officially be entered into a research protocol by their parents whether or not they assent. But it seems to have the same impact here. Now, my thinking is we're not asking about assents. We're asking who's capable of really producing an informed consent. And thus, this isn't an issue for someone treated as a mature minor. But what is the value then of assent, or more to the point, I suppose, non-assent to the procedure?
Yeah. So the question was about assent rather than consent, and which is a notion that, as I understand it, was developed at NIH for pediatric research. And I like to talk about it whenever I talk about pediatric ethics or when I talk to an audience of pediatricians, because I think it encourages pushing down the age at which you need to treat your patients more like they're people. And for me, I think my rule of thumb is roughly, if they're a teenager, really try to get their consent and talk to them about everything that you would talk to an adult legally, and someone 18 or older. And by the way, there was a little question earlier about, where did 18 come from and how did that get to be so popular? And I don't know the legal history of it, but I will say, if you think about the history of the West or the history of the world, 18 was probably viewed as fairly old, because I mean, it wasn't that long ago that free, universal public education and requirement that you go there, that's maybe 100 years old. It wasn't that long ago that we had child labor in factories, and once you were 12, you were basically out of the house and on your own. So I think we've kind of lengthened how long we go to school, and we've lengthened childhood, and we've lengthened education, making it 18 rather than 16 or 14. So, which I think is part of why we're doing that, and we're trying to protect them and get them ready for life in a more complicated society now, but neglecting the fact that in many ways there is much more development maybe than we recognize or are willing to admit by age 13 or so. But that's more the capacity consent. Now, assent, just to talk more about assent. So the rule, at least originally, as I understand from NIH, was age 7 and above. And I like that for a few reasons. One is, I take it to mean that from age 7 and above, you have to sit down with the child and talk to them and make eye contact and talk in terms they understand and treat them like they're a person. And I often think of it as another issue for people that talk about principles of ethics. I don't know if this audience is a kind of thinks principles are okay, or one of those groups that thinks principles is the bane of existence. But there's also the interesting fact that when the book Principles of Biomedical Ethics came out, there were the 4 principles, and autonomy was, the one that people think has become the bully. And earlier was, from pretty much the same authors, was the Belmont Report. But there were 3 rather than 4, and the first one was respect for persons rather than autonomy. And there's, to me, an interesting question, what happened during the intervening 6 months that Beecham and Childress switched from respect for persons terminology to autonomy? And I guess what I think is, there are some obvious differences between them, but respect for persons for me is a broader concept. And you have to show respect for persons even if they are not autonomous. So I like to think of assent as a way to stretch that group of people. So basically, you still owe respect for persons even if they're not autonomous yet. And one way to do that is to explain things to them and not do things to them if they say no. So that's kind of where assent. Now, does that mean that the right to refuse beneficial treatment that has a high chance of success? I don't know. But I would say, just like with the dementia patients who are resisting dialysis and pulling out the tubes and blood's getting everywhere and they're screaming and crying and getting into a fetal position trying to be left alone, if the evidence is overwhelming that they hate this, respect for person says, no, you can't do that. Just because they're a kid doesn't mean you can tie them down, hold their arms behind their back, do things that
that they clearly don't want. So, you know, how, if it's going to save their life, maybe, but it's, I think the value of it, the reason I still like to use it is because it gets me, you know, the old rule of sevens? How many of you went to Catholic school back in the 30s, 40s, and 50s? So do you remember the rule of sevens?
I think I've separated.
The rule of sevens from St. Thomas Aquinas, but of course everything in St. Thomas Aquinas is from Aristotle. And the rule of sevens was the stages of human life are naturally developed into periods of 7 years. And from 0 through 6, you're basically a very young child who needs to live at home and be cared for by your parents, and all you need to do is play, and you will learn what you need to learn developmentally by play. But from 7 to 14, you need to go to school, and you need to learn a lot, and you will mature greatly, so that by 13, you are really coming close to having capacity, or, you know, for him it was high school and college combined, is from 13 to 21. And those are the years where you grow a beard. Something a little sexist there in the ancient Greek. But also develop, you know, your higher intellectual capabilities. So, you know, I kind of like the rule of sevens, and I like the fact that picking age 7 for ascent kind of fits into that very old Greek and Catholic doctrine.
Just as a case example, when I was an intern at UCLA, we had a small child who was like 6 or 7, and she had an osteosarcoma of the proximal femur, a very bad malignant tumor. And the reason why ascent was helpful is this: we were about to do horrific surgery upon her. And she understood that if she didn't have this horrific surgery, she would die. She also knew that it would be a really hard struggle to go through the chemotherapy and the surgery that we were about to go ahead and do. And yet this child had the presence of mind to listen to what we were saying, to consent in her terms, in her mind, you know, where she said it's okay to go forward with a hemipelvectomy and amputation of her leg. And she was able to do that with the grace that I have seldom seen in adult patients in the postoperative period, both in terms of using a TENS unit for perioperative pain, but also in terms of the chemotherapy she got after that. And she had a grasp of what was going on that I thought was quite remarkable. By having her part of the decision-making process, rather than saying, honey, you're going into the OR, you'll be coming out without your leg, and mom's making the decision. She was part of the decision-making process. Now, of course, the question is what would have happened if she had said no. Yeah, then you get the whole question is how you go ahead and educate somebody up to a level where at least she could assent and be comfortable with something which otherwise could lead to her death. Okay? And so I think that with assent in the pediatric population, it can be a comfort for both parent and child to have the buy-in of the child from the parent's perspective, but so also that the child has some ownership as to what is being done to them. Now, granted, then the real snag occurs as to when there's conflict in those circumstances. But I think that in circumstances where there is no conflict, but you're formalizing the information, and there is what I would call a minor manipulation, to use a double entendre, so that they could go ahead and take that information and use it to their own devices for their own best interests, would be helpful.
Yeah, I agree. And that rule, that's a good example of respect for persons, and also how to get patients who are compliant. You know, there are all these debates about all these nasty, non-compliant patients. But in fact, if they feel like you're on their side and they're part of the decision-making, they cooperate with you. And I think that's a perfect example.